Oh, hey, Chris.
Hey Chuck, how are you?
Yeah, I'm doing really well. How are you?
I am well. I am on the 87th headset for this podcast. Got a brand new one and it came in the mail today, and I'm super excited to try out and hopefully less critiques on the audio on my end.
You know, it's unbelievable, really. I have had the same earbuds since we started, and I think I sound good. I get complimented all the time, but I don't know about your
Yeah, you
headset
you sound
issues.
you sound great. And I think there's something about manufacturing back in the 80s, just higher quality, to be honest with you.
It's true, they're oldies but goodies, but then again, I can relate to that.
No joke, I actually had a patient come into clinic today with a tape player that had not the Walkman, a tape player that had an audio like speaker. Like it looked like she was like Teddy Ruxpin, like one of those like old school. We were asking her, we were like, "Do you listen to podcasts?" She says, "No, I like my talking books." So, hey, whatever works.
Absolutely.
So I'm super excited today. We have a segment that was suggested by one of our listeners, and even better, a former fellow. So we should jump in pretty quickly, but also it brings me to the idea that if anybody has any ideas for segments, please feel free to email us, handpodcast@gmail.com. And I wanted to thank Lauren Wessel for introducing me to this podcast called Make Me Smart from the Marketplace team. So I actually learned quite a bit preparing for this segment. Chuck, do you listen to that show?
I'm a big fan of all things NPR, and certainly I enjoy the business talk that they have. But I do like Make Me Smart with Kai and Molly. I don't find the time to listen to it as regularly as I would like.
I think this one has made its way into my rotation, which is hard because I only have a limited commute because we live in St. Louis, not in some of the more congested cities. But let's go ahead and give this a proper introduction. Now, typically, from what I understand, this half full, half empty segment is done on a Fridays during a happy hour. Now, for those of you watching on YouTube, have tried to fulfill this, but I know that Chuck is, in his older age, is slowing down. So he probably has a glass of water in front of him. And it's good to stay hydrated.
Well, full disclosure, Chris, I had a board meeting for an organization I've recently gotten involved with. Well, I've been involved with them for a long time. It's called the World Pediatric Project, and we take care of kids here in St. Louis. We run mission trips, and you know what? I like a little drink when I have to go to a cocktail party and mingle with those I don't know too well. So I'm a little ahead of you, to be honest.
And I'm sure you raised a lot of money. It's a great organization, so I'm sure you accomplished good things, and your imbibement was not in vain. So let's give this the proper introduction, as I've done my homework, and this is half full, half empty, where we give our thoughts, feelings, and predictions on current topics. And we have our guest host, Dr. Lauren Wessel. Welcome, Lauren.
Thank you. Thank you for having me. Excited to join you guys today.
It's so good to see you. We miss you here in St. Louis. It's
I've
been, what, 4 months?
I've missed you guys too. It's been a long time.
Now, Lauren, you have decided that you like fellowship training so much that you wanted to do another one.
So much that my drink of choice tonight is actually coffee because I'm still in the hospital. But I am doing an orthopedic oncology fellowship here in LA. So yes, I'm doing a twofer, I guess.
So tell us what you miss most about St. Louis, besides Chris and myself, of course.
I do miss a lot about St. Louis, a lot more space there. I got to play tennis twice a week. It was nice.
That's
So,
it.
so just for everybody listening, Lauren was our fellow and got to play tennis twice a week. So this is, I guess as close as you get to a lifestyle fellowship, right, Lauren?
Exactly. That's what everyone thinks about when they think of the Wash You Hand Fellowship. It was
So
more that my fiance played twice a week and I tried to join whenever possible.
well done. So Lauren, tell us just a brief snippet about what this segment's supposed to be, and then introduce the first topic, and then we'll just go from there.
So yeah, this segment I really enjoy. Again, like you mentioned, Fridays with Kai and Molly, they quickly go through current topics and say whether they're kind of half full, meaning they're into it, so to speak, or half empty on it. And so kind of a rapid fire of upcoming trends, and thought we might apply this to hand surgery and some of the trends in the field, and get Dr. Goldfarb and Dr. D's take on it. I still haven't progressed to first names, so you might have
Well,
to wait. Well,
We're on a first name basis, so if you'd like to participate in this segment with us, you better make the switch, ex fellow.
Yeah, it's time. It's time. I still remember being the stage where it was call me Marty. It took me a while to get there.
I'm working on it. I'll get there.
All right, Lauren.
But-
So give us the first topic. Now, for full disclosure, Chuck has not seen these. I quickly glanced at them, but it was kind of late at night, so I didn't really read them. So I'm excited to hear what we're going to talk about.
So maybe you'll have to answer first since you got to think about it a little bit.
Well, I didn't really think about it. I actually remember the first one. I remember one of the topics because it is top of the mind for me, but I'll go first. I'm happy to.
It must have started with in and ended with I'm guessing.
Also, full disclosure, I ran these by your other former fellow, Jeff Steppen, and so we've reordered them in what he thought was the most interesting.
Okay. All right. Let's do it.
All right. So our first topic is point of care ultrasound in hand surgery. As it's been emerging amongst hand surgeons, a 2009 study demonstrated that ultrasound performed before surgery by a hand surgeon changes treatment in 21% of cases. It is also substantially cheaper than MRI and takes less time. However, if incorrectly used, it could lead to the wrong diagnosis and inappropriate treatment. How would this affect your practice? And are you half empty or half full on point of care ultrasound?
I'm half full and more than half full. I will say, for full disclosure, I just came back from a course in which I learned diagnostic ultrasound and also learned some newer techniques. Now, I'm still in the process of deciding whether I want to use this in my practice, but it was a wonderful course put on by the Sonics folks up in Minneapolis, and I appreciated learning about it. I have been racking my brain as to the multiple ways I could use it, and I've already started using it in my clinic the day after I got back. So very half full. It has the potential to add a lot to the research for me, and then potentially some of the therapeutic applications. I love it for diagnosing nerve injuries and continuity. And I think that is definitely helpful in changing practice. And then there are obvious implications for avoiding things like nerve studies for some of the more straightforward patients, although I like to think I'm pretty judicious in whom I order nerve studies. Chuck?
So there have been complaints about our podcast that Chris and I always agree. Let's start off with a disagreement. I am half empty. I've thought a lot about ultrasound in the patients that I treat and how it could improve the care I provide. I see two problems. One, I don't know how often I would honestly use it. And two, when I do want an ultrasound, I want a high quality ultrasound, and I have peers at the university who do a really good job of it. So for me personally, I don't see how my regular use would change my practice or improve the care I provide. It could save a little money if I were to do it and not get paid for it versus the radiologist or even some of my partners in musculoskeletal physical medicine and rehabilitation. But I'm half empty. Sorry.
I just billed for it, so see how that goes.
Give me follow up with me on how much you got paid for it.
I found out the documentation that I needed, and I billed for the diagnostic ultrasound, a limited one, of course, and also an ultrasound guided injection. So, we'll see. Half full.
Wow.
Ultrasound guided injection of what?
Carpal tunnel. We've talked about this, and this was actually in a paper that I included in What's New in Hand Surgery last year. And 17% of carpal tunnel injections by hand fellows were incorrectly placed, and 7% were in the median nerve. That's scary as hell. So I think, and I honestly, in looking at maybe I'm drinking the Kool-Aid a little bit, to be honest, but in learning an ultrasound guided technique, I definitely have changed how I would do an ultrasound guided injection.
How would you change?
Oh, good question.
Flatter angle, much flatter, relative to kind of visualizing the needle in both planes. My normal injection technique, while I had not, knock on wood, had not had any issues with it in the past, at least that I'm aware of, it's a little different than how I would approach it now, even if I did it without the ultrasound guidance. So much flatter, much more centered on kind of staying between the pisiform and where I would imagine the radial nerve to be, as opposed to angling a little bit towards it.
Wait a second. Between the pisiform and where you think the radial nerve is?
The median nerve.
Okay.
On the radial side, yeah.
I understand. Okay. Well, let me state it here first. Chris, if I hear that you are using ultrasound for your trigger finger injections, we're done. We're through.
Chuck, somebody, I'm not an old dog, so, I can still be taught new tricks. So, you can keep doing what you did 30 years ago. That's cool. I'm not saying I'm a convert, but I'm open to listening.
All right, we'll have to.
Mr. I was the first to use the volar plate at Wash U. So.
And I'm still using it.
Exactly. Next topic.
All right. Next topic is delayed digit replantation. So reports of the viability of amputated digits supports that it decreases after 6 hours of warm ischemia and 12 hours of cold ischemia, but these are largely anecdotal. Those studies reporting no difference are biased by typical practice. Multiple studies have shown that there's no difference between greater and less than 12 hours of ischemia time. And recently, an article in JHS Landscape questions the evidence behind these protocols. Are you half full or half empty on delayed digit replantation?
I can take a stab first. I'm half full. I think it's, look, we all know the challenge with replant or microvascular surgery that's non-elective is how disruptive it is to our lives. It either happens in the middle of the day when we theoretically have something booked, whether that be a full clinic or or it happens in the middle of the night where we hopefully don't have anything booked and would like to enjoy an evening. But this makes sense, and it's always made sense to me that the urgency is not the same as, for example, a forearm amputation or something like that. And so I like it. I don't personally foresee delaying something 6, 12 or more hours, but delaying it to a reasonable degree based on OR availability, based on my availability, based on family. I don't know, lots of things. I'm half full on it, and I think I need to explore it more carefully, how it could impact, and probably think about certain patients. But I'm half full.
I am half empty in the sense that I don't love the idea. I'm half full in terms of the bucket in the OR is half full of the amputated part. But sorry, that's bad. So for me, I'm half empty because if you look at the success of replantation in the United States, even at the best centers, it's 60, 70%. And I'm quoting a number that came out of the University of Michigan in their recent study in which they looked at surgeon proficiency at an excellent plastic surgery, microsurgery unit. And then our own study, which predated me, but with very good surgeons doing these cases with excellent trainees. And the success rate was also 59, 60%. So I think that it's already a hard enough thing to do in the United States. Pushing it out even further, I think would only increase the pessimism in terms of the outcomes for it, although it may make more people try. I would say the only reason to be half full on this topic would be if that meant that you would actually get the patients to places where they could do it better. So true high volume centers, which one could argue is not the best use of resources because you're taking a patient out of their region, state, et cetera, and everything that comes with that. Now, maybe if you didn't have to helicopter them because you could drive them there, that would save some money, but I'm half empty on it.
So Chris, I know you're multi-talented. Do you believe you are just as good at 2 a.m. as you are at 7:30 a.m. technically?
Most likely not. But also, I think that maybe in some ways, that's a time where I can focus and not have to worry about anything else I have going on. Because inevitably, you have no idle time on your schedule. So even if you bump it to the middle of the day, you're still bumping something else. And I'll be very honest with you, sometimes I take it on the chin for the 2 a.m. because I know it's not going to mess up the rest of my schedule. And I was at a meeting. I think it was the clinician scientist program where we were kind of joking that sometimes, we do things that when we're very tired, and sometimes patient care is the thing that comes the most automatic. It's a lot relatively easier to do some of those things as opposed to some of the more cerebral tasks that we're asked to do.
Fair enough.
Do you think you're better at 2 a.m.?
I'm less distracted at 2 a.m. I think your point is a very good one. I think technically there's no way I'm as good at 2 a.m. as I am at 7:30. But ultimately, if a system were developed, and it does require serious discussions about resources and best care for the patient, for the system, for society, but if the appropriate systems were developed then it would change the way all of this works, and you could carve out time. Some could carve out time for cases like this. So it's a big question. I like the concept. I believe in it. I don't know that it makes life any better, honestly.
Yeah, I think if the volume was there to do something like our orthopedic trauma colleagues do, where somebody's got a trauma room, and whether it's an open distal radius, a mangled forearm, or a digit replantation, if it can go the next day, then it goes the next day, and somebody is just in charge of that room. That is a potential way to make it work in the U.S., or if you have a more hospitalist-based hand trauma team. But I don't think that model exists in any academic centers in the U.S. at least.
Interesting. Well, I think you both will find the next topic of interest as well. So we are on to Wallant, but in this case for distal radius, open reduction, and internal fixation. So the emergence of wide awake local anesthesia without tourniquet has expanded options for surgical anesthesia and is particularly important in our elderly patients and those with comorbidities. And a 2018 article in JHS outlined techniques for plating of distal radius fractures using this technique. The technique involves injection of the tumescent anesthesia in the subcutaneous tissues subperiosteally and at the radial border of the radius. This is obviously more involved than our normal Wallant cases, but are you half full or half empty on Wallant for distal radius fractures?
Half empty for me. I love Wallant, but I think this, clearly, I think this is more of a case of a technical triumph over pragmatism. Now, unless we're in a situation in which I cannot get a block from anesthesia, I can get an OR, the patient for, either they're incredibly frail, in which I'm probably not doing their distal radius, or for example, say they're pregnant or something like that, and for some reason they can't get a block. I would offer it as an option, but it would not be something that I'm trying to champion or push for, just because I think that a block, a wide awake with a block and a tourniquet actually works out pretty well in some patients.
Yeah, not much to add. I think there probably are rare indications in my world, but I am absolutely half empty. For a lot of reasons. I guess if it's a tricky distal radius fracture, I don't want the patient awake. I don't want, I need to be, most of the things that I do awake, and others out there may see it differently. Most of the things that I do awake, I don't need 100% focus, and I can talk to the patient and talk to the trainee, and the case is going to go perfectly. Distal radius fractures certainly run the spectrum, and for anything that's more than simple, I would want to devote my full attention, be assured the patient is not involved in the case in any way. So I'm half empty, not for me.
Would a bundled payment change your thinking here as a department head?
Yeah, of course it would. And maybe in 20 years we'll get there.
And for your mission trips, would it ever change your opinion?
Well, thank you. That's a great question. I guess part of it is, I'm not certain I'm technically competent to accomplish the type of pain control that I would need. So I would need to make sure I could do it successfully. And yeah, I think it could play a role in a mission trip, and it could play a role in a very ill or pregnant patient. But like Chris, I love a wide awake block patient. I think anesthesia can really contribute in that regard. So yeah, there's going to be indications for it. Probably not for me, or certainly not regularly.
Totally fair. Our next topic is dry arthroscopy for reduction aid in scaphoid fractures. So obviously, we typically use our group typically used wrist arthroscopy with irrigation and a saline-filled cavity. However, fluid management can be cumbersome, and the use of dry arthroscopy in the setting of fracture could allow a surgeon to have a clearer visualization and after the hematoma and debris are removed without compromising fixation portion of the procedure. Are you half full or half empty on that technique?
So many people that I respect are advocates for dry arthroscopy, and that's super important. That includes primarily European colleagues, but the most notable person in the States is Sanj Kakar at Mayo Clinic, and he's a big believer. I have tried it a handful of times, and while I can see, no pun intended, the benefits, I am not a believer. I don't love dry arthroscopy. I don't believe I see as well. And I have to tell you, you need to be careful about the instrumentation you use, because not all shavers are designed for dry arthroscopy, and fluid flow is important for heat dissipation and management of the shavers. However, if you are considering an assisted distal radius fixation or a scaphoid, as you mentioned, it can be beneficial. I think it'll be just as helpful to do it with fluid. And like Chris, I've never been sold on the concept of arthroscopic assisted scaphoid fracture or scaphoid management. I think that is also a triumph of technology over reason. Distal radius, hit or miss. Scaphoid's not for me, despite my love for arthroscopy. Half full, no thank you.
For me, the only comment I have is when my children are fighting me on something and I tell them what I want them to do and they say, but why? That's my answer for this. Half empty.
All right, easy. So our next topic is hand surgery education. Surgical educators are increasingly exploring surgical simulation and other non-clinical teaching adjuncts in educating trainees. These simulators range from purpose-built machines that are too inexpensive smartphones or tablet-based applications. As training tools are becoming increasingly utilized, how do we balance this with hands-on teaching and progressive autonomy? And are you half full or half empty on the increasing prevalence of non-clinical teaching adjuncts?
I think I'm first. I'm going to say something controversial. I'm half empty. While I recognize this as the future, I think it's already, I think our trainees are busy enough. I don't see where they're going to do this. They're at least the only context I have is our institution, at least being on the faculty side of things. And I don't understand when you're going to have time to do this, when at least in our mentorship model, you're in clinics, you're in the OR, you're going to conferences, and you have the great problem here at so many people wanting to teach you that you can't even schedule all the conferences. So I don't know how you're going to do this within the confines of an 80-hour work week, because I guarantee you this is supposed to be within your 80 hours if it's mandatory training. So I'm half empty on it, not on the premise of the technology not being wonderful and useful. I just don't know right now where we're going to fit it in, because otherwise you actually would be seeing patients or doing something else educational.
I hate to say it, but I agree with Chris. First, it's important to note that I applaud.
But I took that stance so that you would actually disagree.
Well, here are my thoughts. Number one, a couple of thoughts for Chris. Number one, I may have more than two, but I'll try to limit it to two. Number one, thank you to those who are leading the way in this effort for simulated teaching. That includes people like Ann Van Heest in hand surgery in the Twin Cities. That includes people like John Schenecker at Vanderbilt in pediatric orthopedics, and many others. Don Bay, my friend in Boston. Really important stuff. Thank you. I have been fortunate enough to trial a number of these tools and instruments, and I've been disappointed every time. Not to say it's not cool, not to say it's not sort of fun, but do I think it, at this point, the ones that I've seen have not, in my simple mind, meaningfully added to education. I read a great article recently talking about virtual reality and the headsets and the like, and how far they have come, and how real life the simulators are, and how it's just remarkable. And yet, apparently, don't judge me, I read the article, I didn't participate, they're really used for two things: video games and apparently porn. Who knew? But that's what it is. And so that's where we are with VR and the headsets and the like. And so I'm half full on the future of this type of education. I'm half empty on where we are today, at least to my knowledge. And I may offend someone by saying that, or maybe in the near future.
Yeah, no, I think that the efforts should be applauded. Many of our surgical colleagues in hand surgery, orthopedics, and plastic surgery, and all across the board are putting in. I think that there are probably certain skills that can be learned through the simulator. Clearly, arthroscopy is one of those things that comes to the forefront, and perhaps even microsurgery, just in terms of suture passage through vessels, not being in the back wall, that kind of thing. I think that maybe there is a very narrow couple of niches where this could fit in the world of hand surgery. So yeah, no, I'd be interested to see where it goes for sure.
All right. Our next topic is three-dimensional nerve grafts. So bioabsorbable unfilled synthetic nerve conduits have been used in the reconstruction of small segmental nerve defects with variable results and are particularly challenging in motor nerves. Recently, scientists have developed synthetic grafts that are hypothesized to mimic the Schwann cell basal lamina in the form of glycosaminoglycan matrix to improve bridging. Early studies have demonstrated superior functional outcomes with motor recovery compared to the commercially available empty conduits. Are you half full or half empty on three-dimensional nerve grafts?
I'm half full on anything three-dimensionally printed. I think that is not the future, it's today. This is a little outside my area of expertise. I think there's, things like this have a high bar. It has to be demonstrated to be better than the gold standard. And if it's close, that's not good enough for me. So it has to be equal to or exceed in a cost-effective way. So I am absolutely half full on the future. I don't know enough about the current state to really say whether it's for today, but I'm half full on the concept for certain.
I am half full, but I disagree. I don't think it's today. It's just not ready for prime time yet. For full disclosure, one of our partners, David Brogan, has actually worked with one of our residents, Peter Chang, on a 3D printed scaffold. So it doesn't have Schwann cells, but the concept is there. And I think it's incredibly promising. And then, the big knock on acellular nerve allograft is that product, because of the processing, doesn't have Schwann cells. Now, clearly, all of the work that Susan McKinnon has done in the arc of her career, many contributions, but one of them being the real challenges associated with the immunosuppression from a fresh allograft fresh allograft of nerve that would theoretically have those Schwann cells. I think that this is incredibly promising. I don't think it's now. I think it's still probably 10 to 15 years away. And especially to get it down to the price point against the standard of autografting. Now, many advocates for nerve allograft will say that autograft is not really a gold standard, it's more of a bronze standard, but it's still the standard upon which things will be judged.
Fair. So our next topic will stay on the 3D train. So this is three-dimensional models in hand surgery. The medical application of three-dimensional printing technology has evolved in the last decade with increasing varieties in the use of hand surgery. Printing technology has been increasingly used for the creation of intraoperative aids in regards to both cutting jigs, guide wires, drills, and templates for bone grafting. Intraoperative aids include specific cutting jigs. Are you half full or half empty on the use of this technology as an intraoperative aid?
I'm going to take half full mainly so I can hear Chuck argue half empty. It's interesting. We recently had a speaker from Duke University, Sam Adams, a foot and ankle surgeon there, who has done a ton of work on this in his practice, and using things like cutting guys for deformity correction, malunion correction, et cetera. And I think it's super interesting in custom implants. I think that I don't know where I would use it just now. I think probably for like a complex scaphoid malunion or a complex intra-articular distal radius malunion. I don't see it being a high volume kind of thing for me, to be honest with you, except if we got to the point of 3D printing of implants, which I know is in the immediate future and could be patient customized based on, their preoperative imaging. My big question mark on it, which will give Chuck an easy place to go with, would be the cost. In querying a bit with our guest professor, there was no good answer on the cost of these implants or the use of these models in 2021.
Yeah, I hate to say it, but I'm half empty on this. What we have done here, there's 6 of us, and to my knowledge, only one of us, Dr. Wall, has has taken to this, and I certainly send patients that I do believe could benefit. So for me, it is typically an adolescent or young adult with a three-dimensionally complex forearm malunion that may be affecting stability at the elbow, maybe affecting stability at the wrist. So I do think there can be indications. I just believe those indications are few and far between. I'm not suggesting that even the trained eye can do as well as a 3D planned osteotomy and plate application. But I think for most of the things that I encounter, which I would assume are among the more complex that people encounter, I think I can do just fine and accomplish. And fine's never good enough, but I can get the job done well without requiring 3D printed assistance. Super interesting technology. I like the concept, but time and money, again, it'll get better, it'll get less expensive. I'm shocked that insurance companies are paying for this on a seemingly reasonable basis, but what they're not paying for, the insurance companies, they're not paying for surgeon time. So the surgeon spends time on a Zoom call with the engineer to answer questions and optimize the plan. That's uncompensated. And that's okay. You know, we want to do the best thing for our patients. And again, in some cases, it can be helpful. For me, those are very rare.
Sounds like a lot of oncology cases.
You mean uncompensated care?
That part too.
Time consuming yet uncompensated, but morally fulfilling.
That's what we're going for. So our last topic for today, I would say probably is less controversial, but more commonly written about recently. So nerve transfers for spinal cord injury. So patients with cervical spine injuries consistently rank restoring arm and hand function as their top functional priority to improve quality of life. Motor nerve transfers traditionally used to treat peripheral nerve injuries are increasingly being used to treat these patients. However, there is substantial heterogeneity amongst existing studies, particularly with regard to patient characteristics, renervation stages, and reported outcome measures. Are you half full or half empty on this new emerging research and field of clinical care?
I will keep it brief. I'm half full and I have nothing else to say.
We'll end with some agreement. I'm half full, and I don't see this population, at least at this point. I think that may change perhaps as we incorporate the neuro rehab group into our department. That's just a local change. The people that have done that here in the last 5 to 10 years as this field has developed have been Ida Fox and Zach Ray. Zach is pretty uniquely qualified to take care of these folks just because training as a neurosurgeon with additional peripheral nerve involvement. Clearly the rehab folks think of somebody like him when they think of spinal cord injury patients, and Ida Fox has done a lot of work with the Trizzle group doing some research there. So great work done by both of them. I think that in the right hands, it can be done very well. I think that you make good points about the unmet needs of this population. Just like I've tried to focus the early parts of my research career on unmet needs in brachial plexus injury patients, this is a group that is traditionally, I think, underserved, although a lot of resources are dedicated to them because of the nature of that injury. A lot of DoD funding, a lot of funding from the NIH. I think a shift in the paradigm and how we think about those patients would be useful. And it's a great way, for our listeners who are hand therapists to let us know what they think, because they probably have a fair number of PT colleagues who, they talk about these patients with, because, there are so many, this is such a challenging population. So if anybody has any comments on this particular topic, any of the topics we talked about, would certainly welcome them.
It does feel like the classic statement, which I'll get not exactly right, but a little would mean a lot for these patients. A little bit of change, a little bit of improvement, if that can be provided with the nerve transfer, then gosh, it is. I agree with everything Chris said. I think it has the potential to be remarkably helpful for patients. And you're right. I do think the paradigm may be changing. We may be more involved in their care here in St. Louis. But once again, it's not something that every hand surgeon or hand therapist needs the training in. It does need to be a select group to better understand it and make sure we're maximizing outcomes.
Yeah, because the entire evaluation is different than how we even think of a brachial plexus injury patient. It is very, very different. So then to think that we can just apply our same thinking of plexus patients to SCI, I think is a little bit short-sighted, and clearly we need to immerse ourselves in that experience and how the overall care of those patients in order to truly provide a service. And, I know that Zach and Ida have done that and how they've developed that here, at least in St. Louis.
That's all you got, Lauren?
That's all I had for you tonight.
I think this is fantastic and should be a recurring segment. I'm not sure how easy it'll be up for you to come up with enough topics on a recurring basis, but we could shoot for 6 months, which should give you plenty of time.
Plenty of time.
Well, yeah, and so if anybody wants to chime in and either suggest topics or give us feedback on this segment, or if you just want Lauren to come back, handpodcast@gmail.com. We'll make sure to get Lauren's notes as part of our newsletter, and make sure to sign up for the newsletter. The link's in the show notes. Chuck is always looking for content, and I think I should contribute too. So try to pull my weight on this thing.
I think so. I think that's a great idea.
I'll have to keep a list of topics for the next 6 months. So,
well, we have to keep you engaged in some kind of hand and upper extremity as you dabble in the pelvis this year.
I would be happy to stay up at the upper extremity.
We won't tell your fellowship director, don't worry. Well, Lauren, thank you for joining us and for the great suggestion, and have a wonderful evening. It's still evening in the on the West Coast, so enjoy that.
It is. Thank you. Thank you for having me. It was fun.
Absolutely. Great to see you.
Great to see you both as well.